Hi, everyone. I am Amy Zelmer from Faces of TBI, and welcome to the 2018 Brain Health Online Summit. I am a TBI survivor from a fall on the ice in February of 2014. And myself, along with Dr. Jeremy Schmo at Minnesota Functional Neurology, we saw a need in the brain injury community for more training and education on alternative healthcare methods and modalities for those suffering from the lingering effects of a brain injury. So each weekday during the summit, you will hear from a presenter who will share either their experience working with brain injury patients or their own real-life experience of living with a brain injury. So today I am here with Dr. Ronald Tarrel, and Dr. Tarrel is a neurologist in Minneapolis at the Neurological Clinic and works out of Abbott Northwestern Hospital. He began his medical training at the Chicago College of Osteopathic Medicine, now known as Midwestern University. He went on to complete a neurology residency and fellowship training in neurocritical care and stroke. Dr. Tarrel was one of the original director neurocritical care program and stroke services program at Abbott Northwestern Hospital. In addition, he has had an active clinical practice and significant experience in sports medicine and concussion. He has participated in a number of research trials and has given numerous talks and interviews to professors on a community level on the topics of stroke, head injury, and brain health. He has served as tournament physician for the U.S. Taekwondo Association and is a proponent of both Western medicine and alternative medicine approaches to health and wellness. So welcome to the summit today, Dr. Tarrel.
Thank you.
So happy to have you here. And today you're going to be talking about neural perception. And so I am really intrigued to hear more about this. And I'm just going to let you start and jump on in with it.
Well, I want to talk about neural perception because the effects of concussion are variable from every individual, from every other place, and there's no one way that people suffer concussion. Unlike other illnesses such as stroke, infection, things like that, we know what it looks like, we can predict it, we can make a diagnosis as soon as a person hits the door. But head injury is a lot different because we all perceive our world differently. And one of the biggest problems with head injury, whether it's the athlete on the field or us driving in our car or someone who just slips and falls on the ice, it's that interaction with the world and our perception of the world that changes as a result of what is more likely a diffuse brain injury than it is a localizable brain injury. So we all know how our brain is organized, at least in a gross way. We understand that the left side of the brain controls the right side of the body. Most, but not all people control language on the left side of the brain. We know our vision is in the back, smell is in the front. We understand this localization, and that's a very Western medical way to look at the brain, which is a fine way to look at the brain. It helps us a lot. We can make sense out of it and do things with that. But when someone has a head injury, it's not just where the bump is, it's not just where the bleeding was, but the head injury affects the brain as a whole. And when you affect the brain as a whole, you're not just affecting the brain tissue, you're affecting the environment the brain lives in. And our brain lives in our skull. And it's protected by spinal fluid, and it's protected by the meninges, those layers of connective tissue that surround our brain, surround our spinal cord, and wall off our central nervous system, our brain and spinal cord, from the rest of the world. And there's three meningeal layers. The outermost layer that most people are familiar with is called the dura. So when people have subdural hemorrhages or subdural hematomas, they're talking about bleeding or blood that gathers just underneath that most outer dural level. Then there's what they call the arachnoid level, and people who have bleeding aneurysms, outpocketing of a blood vessel that can have a very thin wall and cause bleeding, those blood vessels live just below the mid layer, the mid-meningeal layer, which is the arachnoid, and so they have subarachnoid bleeding. And then the innermost layer is called the pia, which is pretty much adherent to the brain itself, almost like that thin film on chicken that you can peel off from a chicken breast. It's like that. But our brain is protected. But in those areas of protection, there's fluid, there's blood flow, and our oxygenation and blood flow to our brain is regulated based on the pressure inside our skull. And I could bring it down to a formula, and I won't. But basically, there's perfusion of blood into the brain tissue, which is a description of the force blood needs to travel in to get into brain tissue and provide it with the oxygen and glucose to keep that tissue going. If there's any change in our blood flow going into the brain, the arterial blood flow, or any change in the sitting pressure inside our skull, known as intracranial pressure, or any change in the blood flow going out of the brain, down into the veins and down back into the heart and to pick up oxygen from the lungs, all of that fits into a formula that can interfere with normal brain oxygenation and normal brain nutrition. And so when someone has a head injury, again, it's not just where that injury occurred, but it's how it affects the brain as a whole. And these symptoms that people get, anything from a decreased level of consciousness to a sense of confusion, lightheadedness, dizziness in all its different forms, difficulty with language, difficulty with eyesight, difficulty with hearing and balance, all these tens and tens of different kinds of symptoms that people get, they're very hard to localize. And as a Western medical neurologist, much of what I do every day is based on localization. Oh, he has right-sided weakness. I know there's something on the left side of the brain, or vice versa. Head injuries are different, and how we manage them is different too. So I wanted to call this talk neural perception, because we are exposed to our world and we understand our world in more ways than I'm about to say, but for now, let's just talk about the five senses. We have our sight, we have our hearing, we have our touch, our smell, and taste. And these are things that are commonly interfered with in people with concussion. And when this happens, what's happening is it's not that we're not really comprehending the world as it's coming into us, but we're not processing the information right, and therefore the way we respond to it isn't right. So on a bigger scale, we can talk about a person who feels off balance, yet as if their world is moving, yet there's no movement in their world going on, and they can be standing still and they still have this feeling. People can lose smell, they can have alteration of taste, and they can have changes in the way they perceive others around them and how others perceive them. So information coming into our brain comes basically through those five senses. And when our brain is injured from blunt force or from concussive force, so a lot of the research that's been done was done in the military, soldiers who are exposed to grenades and bombs, sometimes they may not be hit with anything, but it's that concussive force through the air that actually can cause head injury and concussion. And other times they'll have frank and blunt areas of trauma. The first thing we have to do when someone has a concussion is we have to control what we see. If there's bleeding, if there's fractures, if there's injury, we have to restore that. If the brain isn't getting the oxygen it needs and the blood flow it needs, we have to do our best to restore that. But the symptoms that become most troublesome are those symptoms that are plaguing people over longer periods of time. How can we fix that? How do we work with that, especially when it's so difficult for us to interpret what each separate individual is trying to tell us about their injury? Well, in one way, we have to put ourselves in their shoes. We have to understand that what a person is telling us is their perception of their world. And we can't sit here and say, but the world's not moving. Why do you feel dizzy? Everything's stable here. You're crazy. No, that's not the case. Not the case at all. So we have to understand that the people are going to be genuine with us and they're going to tell us what they're feeling. We can do our scans to look for trouble, areas of bleeding that might describe something, areas of bruising or injury. Our brain's bruised just like any other part of our body. We might find that too. And we can work with those areas. We can wait for them to heal on their own, but sometimes that's not the answer either. So real therapy comes in retraining ourselves, and with the help of others and professionals, retraining our ability to use our five senses and understand the world as it is on the outside so we can interpret it and work within it. This is where a lot of the alternative therapies that you mentioned come into play. So one of the things that I would say that Western medicine is not so great at is understanding how critical eyesight and eye movement is to our feelings of security and stability, I mean, physically speaking, in the world. And even though there are wonderful ophthalmologists, neuro-ophthalmologists out there that do incredible work and are incredibly perceptive, they're good at making diagnoses lots of times, but sometimes they don't have the therapeutic part of it. Now, you mentioned Dr. Jeremy Schmo, and he's one of the functional neurologists I've worked closest with over the years, and we've shared patients over time. And he has a way of doing incredible work through interpretation of what these people are seeing, what their balance is in their world, how their eyes move, and developing exercises and treatment strategies so that they can reorient themselves to the world as it really is, instead of a world that is interpreted in a sense wrongly by their own perceptions.
Mm-hmm. You know, and I think for me, my eyes were my biggest battle. And, you know, I had gone to the neurologist, the neuro-ophthalmologist, and everybody kept telling me my eyes are fine, your eyes are fine, your eyes are fine. And like you said, structurally, my eyes were fine. I didn't have like a torn retina or anything. And it wasn't until finding Jeremy 2.5 years later, he was the first doctor to go, "It's your eyes." And I was like, yes, someone believes me.
Exactly. And it didn't take him long at all, I'm sure.
No, like
and
2
so
minutes.
I will let him speak to, you know, the great things that he does and the tools he uses to help people. But again, we have someone who has a different perception. And when you break them apart in little pieces, as we love to do in medicine sometimes, and say, well, your right eyeball looks fine to me, and your left one looks pretty good too. So what's the problem here? They even seem to move together, they might say. But on a much smaller level, they may not be moving together. And eye movements influence vision, but the movement of the eyes and what the eye sees are two separate things. And then that information being transmitted to the brain, and again, this is the idea of neural perception, that information being transmitted to the brain goes different areas. So when eye movement and how that helps us image our world is different than the lens that our eye is and the light coming in, and this over here is controlled pretty well, but now maybe the movement side of it is injured and not processing information correctly, it brings up symptoms that are very difficult for the patient to tell us about. So I had a patient in the past, Dr. Schmo knows this patient very well, who would always talk about rafting. They had a constant feeling of rafting. It literally laid this person up, literally, for years, where they could do nothing but sit in a chair. Most or the ability of the brain. That's okay. Did you catch all that?
No. So the last
back up to where we were.
Yep. So you were talking about the patient who could only sit in a chair.
Okay. So one of the things that we want to work with and we want to use to our advantage is this concept known as neuroplasticity. Neuroplasticity, you know, we're told from the day we're born that we're losing millions of brain cells every day, and unlike our liver and other organs, our brain doesn't regenerate, and it's all downhill from the moment you're born. Well, not necessarily true. There not only is neuroplasticity, where different parts of our nervous system, different parts of our brain can take on different tasks through training, but there's also neuroregeneration to a degree. And there's research going on now where we're using different methods, everything from stem cells to different medications and chemicals that can actually help the brain regenerate itself. We're a long way from that, but they're working on it. But what we can do in a functional way, what we can do is train the brain to recognize the world in a way that works for that person and their brain. And our brain is very good at learning, and it learns through repetition. So when we memorize things, we can memorize, go over the flashcards over and over and over. Finally, we've carved out a pathway in our brain where we're going to remember those things very well. When you're accustomed to walking from your bedroom to the bathroom, well, after 1,000 times of doing that, you probably can do it mostly with your eyes closed and you don't have to think about it. So our brain is very good at learning tricks and maintaining the ability to do those tricks over time, and our brain can grow with that as well. Head injury gets in the way. head injury interferes with those networks that we've created in our brain through repetition and learning. And we have to try and restore those. We can restore them primarily through repetition, but also through the ability of training that teaches us to see things, hear things, smell things, and feel things differently. And again, that comes with dealing with a person's perception and what they feel and taking that as the baseline and working with them to see differently what their own body is telling them and do that repetitively until their brain learns it again and puts them in a more comfortable place.
We have Dr. Zielinski on the summit as well. I'm not sure if you're familiar. She's a Nora eye doctor, and she talks a lot about the eyes and how if they're not working right, and like she uses the example of like a little mouse crawling across the floor, and like it startles us more than it should because like our eyes aren't working right. And it keeps us always anxious and that startle reflex.
Right. You know, people can walk into a room with an awful, awful smell and stay there long enough and the smell doesn't bother you anymore.
Mm-hmm.
People can be on a boat and maybe they have motion sickness, and this isn't, I mean, I know this isn't true for everybody, but a lot of people can ultimately get used to that motion. Their brain adapts to that motion. So again, a lot of this idea is about our brain's ability to adapt to the world around us. Now, when we're injured, we've lost some of the adaptation possibly that we learned over time, and to reinstill that, we have to put our brain through the motions. So if it's a question of balance, we've both been talking somewhat about vision primarily, which is probably our most used and vital sense in a way. But how about our knowledge of where we are in space? There's lots of tricks that people will go through to throw balance off, and lots of circus shows actually where they show balls running uphill and things like that, and you're standing on an incline when in fact the floor is square, and that's the interplay between balance and our sense of our place in the world, what we call proprioception, and then how our eyes react to what we see. And again, if we don't have that integration, if we don't have that neural perception, those channels set up in a way where our vision interacts appropriately with our sense of balance, our inner ear mechanism of balance, our brain sense of balance, which comes from our cerebellum, then we're going to misinterpret the world and we'll think things are moving when they're not. We'll feel like we're going to fall when we shouldn't. And it's all because of this misinterpretation, because those pathways have been disturbed as a result of the injury. So integrating balance with vision, which is what we do every day with virtually every step we take, integrating our idea of movement or lack of movement, this is all really difficult, and it can take a long time because it's retraining our brain. And it's these kinds of therapies that are going to make the biggest difference. And unfortunately, we're getting there. But in the Western medical world, again, we're not really good at venturing out into treatments in the way, for instance, that functional neurologists have been able to venture out into the treatment. We'll diagnose the same things. We can sit across the table and talk about the same findings in any given patient or whatever, but how we treat them, lots of times in Western medicine, we throw our hands up. So our current way of treating concussion, by the books, is you don't challenge the brain when you're talking about concussion. So we know the concussion protocols in football, and what a lot of sports physicians will tell you is that when you've had a concussion, you don't challenge those symptoms to begin with. You back off. You've had a concussion, you're dizzy, you're vomiting, you're not seeing right, you got a headache, you're not talking well. You go lie down. And you just let everything rest, lower stimulation, and it does work to a degree. Don't get me wrong. There's nothing wrong with this, but it has its limits. And then, for instance, like with the concussion protocol in football, well, you were told to go home and stay there. The next step is, well, you know what? You're feeling pretty well, not having any symptoms, walking around your house. You come to a team meeting, but you're not even going to look at the practice field, let alone go out there. If they can do that, then it's, well, come on out on the practice field and just watch everybody go and see how that goes. Some people get lightheaded doing that. They'll get their headaches standing up. Then what do? We say, you got to go back to the last place you were known to be well. And so it's back to just sitting at the meeting. And they work themselves up to it. And then maybe they get to ride a stationary bicycle on the sidelines, but that makes them dizzy again. Now they just have to stand there again, and they'll keep progressing up there. But now with the interventions we have, like the workings with eye movement and our sensitivities that people develop with head injury, sensitivity to smell, sensitivity to light and movement, sensitivity to sound, to reintegrate that person into normal daily life means that you have to reprogram those parts of our senses that aren't tolerant of our normal daily life as they should be. And so not only is this the case with, for instance, players on the football field and things like that, but people who just need to sit in front of a computer. And if you think about it, the things that I just talked about, intolerance of light, intolerance maybe of smell, intolerance of movement, of sound, it begins to sound like a migraine. It begins to sound like a migraine. A migraine is not just a bad headache. A migraine is a syndrome. And the migraine syndrome includes an aura that most people don't, but some people with migraine get, which is they'll see bright lights, or they'll get feelings on one side of their body or the other. They'll have unusual smells. They may feel dizzy or off balance. It could be a number of different things. They may not be able to concentrate well or think straight. They may lose their language. And that's a perturbation at that time of their five senses and interacting with the world and their ability to do so. Secondly, they get the headache. It's usually a one-sided throbbing headache, but it can be just a dull headache. It doesn't have to be a terrible headache. But then they get environmental sensitivities. Sensitivity to light and sound and smell are most common, and many people get nauseous and they have vomiting. Even if they don't have any kind of disequilibrium or balance, those things will happen. When you think about these things, we're talking about extra sensations and feeling the sense of more going on around us than really should be. In my world as a stroke neurologist, if you think about it, people lose things. When someone has a blood clot in the brain and it affects this area of the brain, well, they're not moving their other side. They may have weakness in their arm and leg and a facial droop. They lose function. My friends in medical school used to say, why do you want to go into neurology? People are always losing things. You lose function. In Parkinson's disease, you lose your ability to control your movement. If you have dementia, well, you're losing your cognitive abilities to interact in the world. People are always losing things with neurologic disease. But neurologic spells, of which migraine is a spell, seizures, you might lose consciousness, but extra things happen, and head injury all sometimes involve a combination of things, but they sometimes involve these positive phenomena, this intolerance or poor interpretation of activity around them that becomes annoying and disabling. And so the idea of rest isn't a bad idea to calm all of that down, but to retrain your brain through your senses to tolerate these things that were so tolerable in the past, that takes a lot of work and it takes a lot of time. And again, this is the integration of our senses and our brain function. And it's the kind of exercises and treatments that functional neurologists and others will use to help people regain their familiarity with the world and their normal responses to the world.
So what about someone who does lose their sense of taste or smell? Is there a chance that they'll be able to get that back?
There is a chance, and smell and taste are very integrally related. Lose one and often it affects the other. Usually smell affects taste more than taste affects smell. But yes, there is a chance. Now it's hard to retrain that, but people will do that. So I had someone the other day who had lost, and it was a head injury patient, and he had lost his sense of smell. He lost it qualitatively. He didn't lose it in a quantitative way. So when he walked by someone smoking cigarettes, he smelled something, and this is him talking, but it wasn't a cigarette smell. When he walks into a restaurant, he smells things, but he can't tell you it smells like pizza in here or steak in here. I mean, he couldn't
Yeah.
tell you that. He smelled things, but he didn't know what to make of them. So again, that's that reintegration of our senses with how we interpret the world, and the ability to retrain, oh, this is what this kind of food smells like, or this is what, cigarette smell or this pretty candle smells like, and to go through it and learn what that smell is. Now, you're not just, here's the key thing, you're not just giving a false name to something that doesn't smell good anymore when it used to, at least hopefully not, but you're actually retraining your brain to say, oh, I love the smell of vanilla, and I'm going to work at that. And you smell vanilla, and then you put another variable in it. When you get used to it and you say, okay, I know this is vanilla, but you can hold any one thing up to me and I'll know it's something. But then you start mixing things up. So it's the gradual reintegration and reorganization of the pathways in our brain that'll help us recover from head injury of all types. And again, smell is one of our key senses, eyesight, our balance through touch, and our sense of position in the world. These are all the things that head injury is so famous at interfering with, and interferes with in a way that it's not an obvious deficit or loss of function, but it's a disturbance of normal function. It's extra stuff getting in the way of your interpretation of a pure smell, clean eyesight, your feeling of balance in the world, feeling of touch and position of your hands in front of your face or up or down or whatever. It takes a lot of work.
Mm-hmm. And I think you've really hit on a lot of what I hear people talking about in my group. It's the rafting. It's the constantly feeling dizzy. It's a lot of people do lose their sense of smell. I lost mine for a very short time. It came back pretty quickly. But mine was more, I lost my sense of taste. Nothing tasted right. But the eyes, the balance, ringing in the ears, those kind of things. And we're so often told, oh, it's just positional vertigo, and nobody does anything to help us. And I think that's where the frustration and the despair comes from for people. They get really depressed because they don't think that they can get better.
So let me go a little neuroanatomy on you. So our hemispheres is where all of our cognitive, our cortical functioning goes on. That is where interpretation of the world is. But all that information not only has to come up through, but goes down into our brainstem. So you have all this information up here that comes down into something about as big as your thumb, and that's your brainstem. Now, everyone's learned this before. I hope you've all forgot it because it wasn't all that important in everyday life. But in the brainstem, there are 12 nerves. They're called the cranial nerves, numbered 1 through 12. And the top nerve, which is kind of a different one, is called the olfactory nerve, that smell. And then below that is the optic nerve. That's the nerve that goes in the back of the eye and helps our eye see. It's the workings of the camera, basically. And then there's 3 nerves for eye movement. There's nerves that then control our facial movement. There's nerves that control our ability to swallow, our ability to cough, and it goes down our ability to move our tongue. It all moves 1 through 12 like that. But what you're describing is what we have is in our brainstem, which is the not thinking part of our brain, if you will, but it's the storage of and transmission of information. It's the Union Station, basically. Everything that comes down through the brain, all the messages we send out have to go through there. All the messages coming in have to go through there. But the perception of those things, that is what is thrown off in your, I'm going to say this, in your typical brain injury. So our ability to smell, there's nothing wrong when you walk into a place and you say, I can't smell anymore. Odds are your brainstem and that first cranial nerve is working just fine. But there's been a block in the road that prevents your cognitive recognition of that smell. And if it's not a complete block, it might be a little detour that makes it smell less like what it used to, or cause a different reaction in you than it used to. And so it's all that pure information from the outside world is taken in a very pure way, all the way up to the level of our brainstem. But we lose our integration. We lose our ability to interpret that information in the ways that we were accustomed to. I'm not going to call it right or wrong, but in the ways we were accustomed to that allow us to move through the world in a comfortable, fluid, and effective way. And that cognitive retraining, that's very difficult for us. We can work an arm and a leg that went weak from a stroke to some success, hopefully, not always, but at least we know what we got to do. It's very mechanical what we do, but it's much more difficult to reintegrate those pure physical inputs and sensations and deal with them from the top down. We lose those connections. And that's what happens when your brain gets rocked around in your skull. From a concussive force, from a blunt force, it's that integration that we lose.
Yeah, and I know Jeremy also explained, you're talking about the brain stems, like the size of your thumb, and he explained, because I had a lot of whiplash, and it's almost like you wring out a towel, and that's sort of what's happening in that brain stem when you have that whiplash motion, and it jumbles everything up.
That's right. That's right. And I had talked about the coverings of the brain and the spinal cord, the outermost meningeal layer, the dura. There is a whole science, and very good science and treatment modalities about dural stretching and dural tone that often, is interfered with from injury. We are very delicate systems. We're very durable on the one hand, but there's, millions and millions, if not billions of connections that have to be kept in place so that we understand the world today the same way we did yesterday and the same way we do tomorrow, and can interact and move around in it in that same way. And any little disturbance, just shake it up a little bit, can interfere with that interpretation of the world, with our ability to integrate the world into our brain and then respond to it in a way that makes us feel comfortable and effective and live our lives that way.
Well, Dr. Tarrel, this has been fabulous. Is there anything you didn't touch on that you wanted to make sure you talked about, or have you covered it all? This was great.
My brain actually was going 100 miles an hour, so there's a lot of stuff I think I didn't cover. But that's because this topic is so big.
Yeah.
Our knowledge is getting better, but even in, the great experts, yourself having suffered through a concussion, Dr. Schmo is a functional neurologist, and all the other experts you're going to have, we're just touching the surface.
Mm-hmm.
And there's a long way to go, because we don't quite understand on a deep, deep neural level just how all the connections in our brain work, how to reestablish them, how to maintain them, how to improve upon them, and how to cure them, or heal them, I should say, when they're injured. So a lot of room to move, a lot of ideas out there. Listen to everything, and I encourage everybody to kind of take everything, not with a grain of salt, but take everything with eyes open and a willingness to understand it, and you'll find that you get your own ideas and own interpretation about what it is to have a head injury, what it might be to help people with head injury, and what kind of treatments you yourself might even come up with. So.
Yeah, and I think we know so much more than we did 5 or 10 years ago already. It's going to be interesting 5 and 10 years from now, how much more we know.
I will say that I didn't touch on, and I worked with the American Academy of Neurology, and they have a whole concussion program, and they put out a whole, statement about the diagnosis, management, and treatment of concussion. And I really didn't go into that part of it where they're talking about the physiology, the Western medical science behind concussion, and the tau proteins in people with CTE, and all of these things that we can see and measure, because that is even at a more primitive stage than everything else we've talked about. We're going to work at that for a long time, and it's going to help. Western medicine is a very great thing, and it's going to help, and it's going to make a difference in what we do. But right now, I think some of the best gains to be made are working with what we know, which is what we feel, what we sense, how we interact with the world, and trying to improve that interaction through trial and error and repetition and a little bit of training from people who know.
Awesome. Well, thank you so much for being a part of the summit. This has been a wonderful discussion, and I think you were really able to put things into terms that are understandable. So I hope that people really got some good takeaway from this today. So thank you.
I hope so. All right. Thank you very much, Amy.
And thank you everyone for watching. Just a reminder, every weekday during the summit, you will hear from one of our presenters. And if you are not able to catch all of them live, you can purchase the recording for $29 with the proceeds going to the Brain Injury Association of America. So thank you everyone, and I'll see you in the next episode.